Welcome for today. I know a lot of you have been looking forward to this conversation for quite some time, actually. Um, Vaccines in general have been quite a topic the last few years, so more top of everyone's mind than they might have been otherwise. Today, specifically, we're here to talk about childhood immunity and vaccine optimization with Dr. Taylor Bean. You can see her on the screen here with me. And Dr. Bean is one of a few naturopathic doctors in British Columbia that administers vaccines in her office. And she's worked with families internationally and now in Canada around vaccinations, along with lecturing on the topic as well in local and international conferences. And she says as well that vaccines have certainly been a hot topic in the last couple of years, but there have always been questions around schedules and efficacy, what to take pre and post vaccines, or what effect certain SNPs may have. And so because many of us are working with clients on a daily basis and getting questions about vaccines, she's here to shed some light on how to respond to some of those questions and better lead our clients whatever way they decide to go. So I've got a little bit here for those of you who don't know Dr. Bean. She is a naturopathic doctor, as I said, and she's the owner of Tailor Made Wellness in Salmon Arm, BC. And becoming a mother is where her core value of achieving informed consent was born. While her profession taught her to be curious and treat each patient individually, it was her positive birthing experiences that changed her perspective on what a true doctor-patient relationship means. Her career started in Singapore, where she supported patients all over Southeast Asia and now has been supporting Canadians since 2016. And Dr. Bean has been drawn to supporting women to achieve an optimal pregnancy, labor, pediatric wellness, and some more complex ailments that involve looking into methylation, genetic variants like MTHFR, chronic infections like mold and Lyme disease, and complex pediatric conditions like ADHD and PANDAS, along with digestive complaints. So welcome, Dr. Bean. Thank you for being here and joining us today.
It's my pleasure. Thank you for having me. Awesome. We can start.
Absolutely. Take it from here.
Okay, excellent. All right. Well, thank you for having me. It's a lecture that I adore giving. And you're going to get what I deliver at conferences. So it's, it shouldn't be over your head. It might be, it's a bit more, but I do that on purpose because this is a conversation that requires in-depth understanding. If we're going to have a more in-depth conversation, we need to understand what we're talking about. So I want to share with you what I think at a level that all of you can understand and go backwards and read it again. So a little bit about me. So I'm a mom of two. Again, located in Salmon Arm. You spoke of the things that I really started pediatrics and then went from there, and therefore vaccines came into that conversation. Started in Singapore, there was mandated vaccines, and again, that's where it started. Parents that were very curious, a lot of questions, and I did not know how to answer those questions. So when it happened twice, pretty close to each other, and I thought to myself, okay, well, they're asking very intelligent practitioners in Singapore who can't answer their questions. I want to be able to do that. So on was my journey to understand more around vaccines. And then we moved back to Canada. As naturopathic doctors in British Columbia, we can administer vaccines age 5 and over, the same as pharmacists. That's the age. And so I took that course when I moved back. It was quite new to offer the course. I was maybe number 11 that took it. But I'm probably the only one that really utilizes it because it's such a big part of my practice and offering that service to patients who want a safe, meaning comfortable place to have a vaccine and have a comfortable space, safe to discuss vaccines. So I offer all of it. So from the conversation to the actual vaccine, and that has worked very well in my clinic. Okay, so there's a lot missing to this conversation. And these are sort of the things that I picked that I think are most useful, be it I can demystify a few things that seem to be at the top of the conversations and better for you to understand. and to be it guide, help your patients too. So, I mean, part of why I want to do this is really because obviously, as we all see, there's a yes and a no side, and that just seems to be it. Either don't do it or do it, and the other, there's just a lot of anger between both and arguments. But there's a huge middle area, massive middle area, and those that aren't on either side, or is somewhere most are in the middle. And really, what that can include is simply just want to have a discussion. I have questions. Can we just have a conversation about this? And as a practitioner, to me was, yeah, I want to be curious with all of you as well. You have questions and I don't have an answer, therefore I should probably try to find it. And so that's been my journey almost a decade now. And so as clinicians, I think we should really be unbiased, open to learning more, always determining trying to find those absolutes, looking to optimize, and really not be hesitant to change an opinion in the face of new evidence, because that happens in a lot of areas of medicine. All right, infant immunity. Infant immunity is a place that I want to start because this is where a lot of vaccines are within the first year of life. So I think it's important that if we're going to be using something that utilizes the immune system, we should look at the immune system and be it if it's different in a developing child versus fully developed. So just sort of aspects of the immune system. We're not going to go into deep detail, but just to understand sort of some areas in terms of lines of defenses. And our first line is going to be our skin. That includes our mucous membrane. So you think when you breathe things in, we have a mucous membrane from the nose, mouth, all the way to the anus. And that part is exquisitely important when it comes to fighting off infections. Your secretory IgA of the gut to be able to sequester those antigens and poop them out rather than them going systemic. And then now we have the immune system is triggered and when you're going to fight something. Then the second line of defense is going to be our innate immune system. And so where they're going to phagocytose infections that they see. And then we're going to make memory to that. So that's the last line, is that we're going to have an immune system that can remember. So I'm going to make it really simple as possible. We have the innate immune system and the adaptive arm to the immune system. So two arms that we're looking at. And now the innate immune system develops in the womb. Macrophages, which are part of the innate immune system, are what eat away the web between our fingers as we're babies. So they phagocytose. And they are what are going to stimulate the adaptive immune system, but they are activated by adjuvants in vaccines. So they respond. So this is just a schematic of the top looking at the different types of white blood cells that will be part of the innate immune system and what their roles are within that. They each have their own overlapping roles, but specific roles that they have. And we see a lot of more of neutrophils, macrophages within, we're talking about vaccines. And then we get into the adaptive side, meaning memory. And then we're going to have that conversion of the CD4 naive T cell into Th1 or Th2, which we're going to focus on that. And then, of course, there's some other ones, the Th17, Th20, but looking at the importance of Th1 and Th2 in terms of development. So the adaptive side is the side where we get memory, and there's parts of the adaptive side that start to be developed around 6 months. So the adaptive side was specific cells that memorize. So we have your T cells from the CD8 to CD4 B cells. And essentially we want to eradicate, kill, but we also want to remember. So at birth, so B and T cells are present, but now we have to talk about cytokines, which are communication molecules between white blood cells. So Th1 and Th2. So Th1, what's interesting is that these cells are unable to make interferon, and therefore dendritic cells are making less IL-12 and cannot stimulate T cells to make interferon gamma. So no Th1 response without interferon gamma. And this could be because it's unsafe for a newborn to mount a large teach one response at birth. So it's actually not developed, not utilized at birth due to being unsafe. And that's going to be because there's a lot of inflammatory cytokines that are utilized. Teach 2, however, is available at birth, and that's because there's a lot of interleukin 4 that's made at birth. And we'll get into the differences between what the responsibilities are, but teach 1's responsibility essentially is to make memory to viruses and bacteria. Teach 2's responsibility is to make memory to food proteins. So they have their 2 sort of main responsibilities. Interleukin 4, interestingly enough, is actually, it's high in infants because it's also part of memory and learning. So it plays a role in non-immunological functions, which is kind of cool. That's also why it's there. So when we look at CD4 naive cells, and so then the differentiation into other Th helper cells, Th1 and Th2 is we're going to need more of that interleukin 12 in order for that differentiation to occur. And IL-4 is helping with that differentiation, which we have a lot of when we're born, and therefore we get Th2 development, which is then therefore more so around allergens and making memory to food proteins, which is coming from mom through breast milk. So learning that's a banana, that's whatever you're eating as a mama, baby is making memory to that. So those 2 arms are really important here in the process of making immunity and memory in an infant. So we have a dendritic cell, which lands on a naive Th4, CD4, and then we've got the release of those interleukins to then make the creation of Th1 or Th2. So the question that is a lot of parents will have is, can an infant make immunity? Is that possible? So this is a paper that comes from Dr. Paul Offit. May know that name. He's a medical doctor in the United States. He's a vaccinologist. He patented the rotavirus vaccine. So he writes these papers that are addressing parents' concerns. And this one specifically is around if infants are able to make memory to multiple antigens in vaccines. So he addresses that, and he says within it, yes, they can. Now within that, he cites this paper, which is quite an important paper. So this paper, it's actually a really cool read to go through. So some highlights the paper says. So it says that essentially giving vaccines early in life are there to prime the immune system. It's just priming it. Now, T cell responses may be enhanced in early life with use of adjuvants. So adjuvants are used, primarily it's aluminum, is the adjuvant to stimulate the immune system to respond to the antigen. So you give a vaccine in the arm, which is an antigen, which is bound to the adjuvant, which is aluminum, and then that stimulates the immune system to respond. Otherwise, it wouldn't even respond. So those T cell responses can be enhanced by way of using an adjuvant. Now, vaccine-induced antibodies against most viral pathogens, so you think measles, mumps, rubella, Hep B, and so forth, are actually unable to totally prevent viral replication and infection, as this requires, as they say, both antibody-mediated neutralization and cell-mediated direct and indirect effects. There's a lot of things that are required in order to make memory. IgG and IgA responses to viral and bacterial infections remain relatively weak in the first 12 months. So they don't see those immunoglobulins very high in an infant in the beginning. So the key point is that most vaccinated infants have low or undetectable vaccine antibody concentrations as early as 6 to 9 months after even completing all of their primary immunization series. So therefore you repeat. So in BC, we do 2, 4, 6 months, and then we repeat at 12, and then we repeat at 18 months. So there's a lot that's repeated at 12 months. And then we have one vaccine that's given at 18 months, because then you're in a window of time where the infant's body knows how to make immunity and more long-standing immunity. So administration of a single vaccine dose at birth induces weak antibody responses, even in the absence of maternal antibodies. Mama can interfere with making memory, particularly pertussis. If you've had the vaccine in third trimester, her antibodies do intervene in the baby's ability to make memory to pertussis, which is interesting. So the percentage of seroconversion, meaning give an antigen to make an antibody after the first vaccine dose given at birth, may be below 10%. And early administration of subsequent vaccine doses is essential for protection. There is a locked-in nature of Th2. So they're recognizing that Th2 is dominant for an infant when it's born, that Th2 is dominant. And then therefore we need to use more driving formulations to get Th1 to respond more, because Th1 is what we need in order to make memory to viruses and bacteria, both vaccine-induced and natural. So this paper looks at T-cell mediated immune responses in human newborns. Are they ready to learn? Can they learn? So they're recognizing there are several areas that limit Th1 type responses in early life. They say that Th1 responses in utero are actually toxic to the placenta and are inhibited by IL-10 and progesterone. So there is a protective mechanism that the infant's body is built to not be able to make memory in early days because it's inflammatory to make memory. This is another really good paper, basically lays out sort of the mechanism of how this all works in terms of Th1 and Th2. So they wanted to look at the mechanism contributing to a Th2 immune dominant, why infants are more Th2. And so they looked at mice that could mount antigen-specific Th1 and Th2 after there was stimulation, meaning using an adjuvant. And so, but they noticed upon recall of the antigen that the Th1 cells died while Th2 was not affected. So there was a very blip. Here we are, and now we're not here anymore. And here we are, and here we're not anymore. And so the apoptosis, the death of Th1 cells, are driven by IL-4, and babies have a lot of IL-4. So we'll see there's a negative feedback loop that comes due to having a lot of IL-4, which a baby is born with for memory and cognition development. So the Th2 bias immune response inhibitory effect of IL-4 on the development of inflammatory Th17 type responses could represent a major regulation mechanism. So the mechanism in place that a baby's and infant body has in order having high amounts of IL-4, and the infant's body is trying to down-regulate Th1 development, knowing that it can be toxic because it's inflammatory. But we can stimulate Th1 by way of adjuvants. So that's the solution to get Th1 stimulated. So the Th2 bias impairs Th1 and Th17 type immune responses in early life. Neonatal immunity is typically considered to exhibit an anti-inflammatory profile. Treg seems to occur early in life, which is good to know. So during pregnancy and weaning, the developing immune system actually faces allogeneic stimulation. So the fetus and neonate indeed encounter maternal allogeneic cells that present what's called non-inherited maternal alloantigens and are transferred across the placenta and then through the breast milk. So exposure to NEMA can also lead to priming of cytotoxic T1, Th1 T cell responses when the dose of NEMA is low. So essentially when you're breastfeeding, mama is providing these non-inherited maternal alloantigens, which is down-regulating Th1 as well, because the infant realizes that it's receiving information from mama, and mama is going to take care of it by way of providing passive immunity. So she's going to take care of me, therefore I don't have to deal with making memory because she's going to take care of me, and I'm going to make memory to food proteins instead. And high doses being associated with the development of Treg. Oops, back. So what does this paper suggest is that when infants' immunity is activated via adjuvants, Th1 can respond, but then apoptosis or death of those cells immediately takes over. IL-4 has a protective role by way of downregulating Th17, and Th2 actually downregulates Th1. And lessening exposure of NEMA allows for priming of these cytotoxic plus Th1 cells. So when breastfeeding starts to reduce, which is typically around 6 months, is when reduction of breastfeeding typically occurs. So then this is just a picture of looking at Th2 develop at birth. We have Th2 coming in at 9 months. There's a very, it's not like right then, but at 6 months, there begins to be development of Th1, but we really see pronounced Th1 at that 9 months and onward. That ability to make memory to viruses and bacteria really do happen 9 months on. We get really good seroconversion from an antigen that the body receives to make long-term lasting memory is where that sort of point is. So I wanted to make a clear point on infant immunity, because there's this discrepancy claiming that infants can make robust memory to equal protection. And that's not what the literature is saying. Essentially, that vaccines at that time period are, be it priming, and they will get a little bit of memory, but that memory will decrease soon thereafter. So if when a child comes to me and they've done their 2, 4, 6 month vaccines, there isn't much memory left from that exposure. We're almost dealing with a blank slate when we start at 12 months because it's a time period. So infant innate immunity means this immediate response, and then can stimulate, vaccines stimulate or natural stimulates the innate immune system. Adaptive immunity is memory. So you've got your innate immune system that responds to the infection, and then they go off and then they tell your B and T cells to kill it or memorize it. Now, vaccines will stimulate the innate immune system, then adaptive. However, vaccine-induced immunity typically only provides a very limited amount of time of memory versus natural. Therefore, that's why there are boosters. Passive immunity means memory coming via breast milk. So the question might come up of like, well, why are we doing things so early? Now, we have to understand is where decisions have come from. And most of the world, and it does, copies what the United States does. So the United States, mothers only pretty much breastfeed until 3 months, because then they have to go on maternity leave. So then now they leaves infants vulnerable. So as a result of that, they've implemented the schedule at 2, 4, and 6 months. For the United States does be at birth, but the most of their vaccines are 2, 4, 6 as well. And then the CDC has then educated other public agencies globally of their strategy, and all countries have implemented that same regime as a result. But that's why the US implemented it, which I think is important to know the history where this came from. People say, well, just because you're going in for a baby well check and therefore that's why they're doing it. No, it's actually because mamas reduce their breastfeeding and they go back to work at 3 months. And so then they just made a schedule because that's easier than having multiple different decisions based on what you're doing in a visit. It takes 2 seconds to understand what you need to do for a 2-month-old. And when you're dealing with millions of people, you're not going to make a mistake. And so then I agree with that, because you don't want to be making mistakes in terms of, did the kiddo get, or should they get, or what's going on here? You have a schedule. And so then that alleviates room for error. Okay, so then I'm going to shifting gears, and I'm going on to adjuvants. Should I continue? Is there any questions around that piece at all?
I didn't see anything come in the chat or the Q&A.
Okay, then I will move on, because it's kind of like we're going in chunks, so I can, sometimes it's sort of stay in that chunk and I can answer. All good. So adjuvants, we're going to move on to adjuvants. Oops. Okay. Aluminum. We're going to talk about aluminum specifically because it is the main adjuvant that's used in vaccines. And an adjuvant means to stimulate the immune system so it responds. Thimerosal mercury is not an adjuvant. So people say that it is not an adjuvant. Aluminum is an adjuvant, or tetanus toxoid would be an adjuvant. But an adjuvant simply means to stimulate the immune system. So a lot of people will say that they compare aluminum in food to vaccines. They're the same. There's more in food. Therefore, that equates to meaning that aluminum in vaccines is safe because there's more in food. So I want to just dissect this a little bit because you see the memes out there that are grossly incorrect, but I don't usually have the energy to dive in and help them understand. So I'm just going to educate people that want to listen. So we look at aluminum. So we've got two arms here. We have food, well, air, food, baby formula, because that's where a lot of exposure of aluminum would come from for a baby, would be the baby formula. Now, the type of aluminum in baby formula is different. It's water soluble. So it's silicate to citrate. It's water soluble. And whatever you eat or drink, or if your food was cooked in aluminum foil, you're only going to absorb 0.1 to 0.3% of it. So I do not get excited about aluminum foil. People make a big deal about it. I do not. Because you're not absorbing a lot of it. And what you do absorb is going to be water soluble. And there are things we can talk about how to pull that out. So that's, although I do look at aluminum levels on hair analysis, I don't get excited about, the things that we use. Perhaps, yes, antiperspirants, because that's a different absorption and straight to like the lymph is right there in your, the auxiliary lymph nodes are right there. However, just knowing that it's very difficult to absorb aluminum. Mercury, however, is very easy to absorb. About 95%, whatever's in the food you will absorb through your gut. So it's really easy to absorb, but aluminum is not. And then it's water soluble, and then your body should be able to move to get that out. Now in formula, it's stated about 250 micrograms per liter. And then, then they're consuming every day, baby formula, particularly if you're, born C-section and you don't, or C-section or not C-section, but you're not breastfeeding, and be it your baby's exposure is right from day one and onward. So that is aluminum in food. Now, aluminum vaccines. So aluminum in vaccines are different structure. So we have aluminum phosphate salts, hydroxide salts, and then we have the hydroxyphosphate sulfate. And this is the third one here, is a patent formulation reserved for the Gardasil vaccine. So it takes basically all the different types and puts them together. So it's very potent and makes that vaccine very effective to make an antibody. These salts then dissolve. Some particular ones will dissolve a little more slowly and some a little more quickly in terms of their dissolving at the injection site. Now, when you inject, you have 100% presence or absorption, but presence of it within the arm when you inject. Then what happens is that the aluminum will slowly dissolve into a water soluble, and then also a non-water soluble microscopic particle, which has high antigenic absorption capacity. So the non-water soluble form binds to the antigen that's in the vaccine, and then the rest of the aluminum goes away. But that's the how it becomes an adjuvant, is because it's bound to that antigen to stimulate the immune system. And that part's important. If you eat it, it's not going to be absorbed in and then bound to an antigen and then become an adjuvant. No, because it's just going to move out of the body. But in this regard, the type of aluminum used allows for it to split into a water soluble and a non-water soluble form. Now, the amount in vaccines can range from 250 micrograms to 800 micrograms per one vaccine. And then that adds up if you're going to do multiple, but that's just at that one particular time. which is less than what if you're eating it every day, then that you think compounding, but you're not absorbing much of it. But with the vaccine, you do get exposure of it. Oops. Now, safety of aluminum and how they've determined its safety. So the last paper written was in 2011 by Mickis. And so the CDC has used his paper to illustrate that aluminum is safe in vaccines. Okay, so his paper, he created what's called a minimum risk level, an MRL, which is a safe amount of aluminum that can be consumed for a long period of time with no negative health effects. And so the safe body burden was actually determined based on ingestion, consumption is what is based on. And where he got that from was he uses a 1 milligram per kg per day from a 2008 report by the Agency for Toxic Substances and Disease Registry, which they created based on rats eating it. And what's really interesting, where's my flip chart? There's a flip chart that we all get as those that vaccinate. It's supposed to be right here beside me. I don't where it is, but it's a flip chart. And in the flip chart, they reference Mickis and they reference the Agency for Toxic Substances. So information is within the BC CDC flip chart manual for us that vaccinate, which is great. They've taken it to another level of education because patients have questions. And I think you have a right to understand if you want to understand. And they do provide that. So when I made my first webinar series, the flip chart wasn't made. So what's kind of cool is that my information has aged gracefully because now it's within the flip chart, which is pretty cool. So the 1 milligram per kg per day is based on rats eating 26 milligrams per kg per day of water-soluble aluminum salts. And then they create what's called a NOEL. So know that the 1 milligram per kg per day is actually an extrapolation for human using correction factors. So the 1 milligram per kg they've used as a safety limit of how much a human can consume based on rats actually eating 26 milligram per kg per day. So they've like, okay, well, let's just dial it back to 1 milligram. And we're going to give that as a safety limit for consumption for humans. So the NOEL is no observed adverse effects level. So the rats were eating 26 milligrams per kg per day, and they established a NOEL based on that amount of them eating every day. And it's basically the largest oral dosage of anything that does not cause any adverse effects in animal experiments, because that's what the Agency for Toxic Substances Disease Registry does, is they just look at all the toxic stuff, give it to animals, be it they have human experiments as well, and say what is the maximum that typically it's probably all rats that they're using or monkeys can consume without noting that these animals are having adverse reactions, and then we'll apply that to humans. So the NOEL is often used to estimate a maximum safe dose in humans for toxic substances. So Mickis used this information to apply to vaccine levels, and vaccine levels therefore do greatly are under that minimum risk level, because 1 milligram per kg per day far exceeds what you would receive in a vaccine. And then the MRL, he did also take another study where they used one male subject, one man, where they used IV, and they tagged the aluminum and then watched how long it took to come out of his body. So we have oral and IV aluminum to then create what is safe for vaccine injectable aluminum. So Paul Offit, he wrote another paper addressing parents' concerns on excipients, adjuvants, and so forth used within vaccines. And what's interesting is actually in his paper, he cites an older paper from Keith, who determined that aluminum was actually a safety level of aluminum was 62 milligrams per kg per day that rats were ingesting. So the level was actually wrong because he didn't cite McKiss. But what's interesting is that even today, there's new literature demonstrating that oral aluminum causing adverse reaction on rats has an upper limit of only 3.4 milligrams per kg per day, which means we need to make a new minimum risk level. A new level needs to be created as a result of these new findings. This is the paper that McKiss wrote in 2011. Super easy to find, but that's the paper. Now, my question and some of our questions on the aluminum front, could the pharmacokinetics of injected aluminum be different? So McKiss's analysis is a reasonable way to estimate the toxicity of retention of water-soluble aluminum released by those aluminum adjuvant particles. But he unfortunately does not establish a safety of low solubility persistent aluminum adjuvant particles. And aluminum vaccines are nanoparticles. And there's all of these papers that which I've cited. Aluminum adjuvants slowly dissolve because of the form of the aluminum adjuvant and not the particle size. The type of aluminum that's used in vaccines is different than just frank water-soluble aluminum. There hasn't been any human studies with intramuscular aluminum adjuvants, and the aluminum adjuvants have, so Movis did a paper where she took babies that received all of their vaccines, I think it was after their 2-month series, and then analyzed over 48 hours, looking at their urine and their blood and seeing if there was any aluminum in those 2 tissue types, and there was not, and therefore deemed aluminum safe because they didn't see it in the tissue. But I think the next step to that study should have been go longer and then also determining about where. And so to me would be, you didn't find it in the blood or the urine is because it was phagocytosed. I mean, that's the point, is it for it to be phagocytosed, because then that an innate immune cell is going to bring it to your lymphatic to present it to a B and T cell to make memory to it. That's the point. So you wouldn't find it. The aluminum vaccine, so this comes from the same paper that that Paul Offit talks about, parents' concerns with excipients and adjuvants. And so he lists here the vaccines that which you would find aluminum in them, and then the amount. He puts them in milligrams, not micrograms though. But in Canada, a lot of these we don't have. We don't have just a DTaP vaccine. We don't have we have the TD, but we don't have the 3-in-1. So there's some vaccines that we don't, like a hepatitis, we don't have that. So some things on here we don't have, but it's just for interest to note that that is what Paul Offit is sharing. And I think it's important to take it from people that are spokespeople and in this world, and I'm using their information. So optimizing vaccine efficacy.
Can I jump in? There was one question on the aluminum front. So it says, my understanding with the Gardasil vaccine is that the polysorbate 80 carries the aluminum across the blood-brain barrier, which is why some girls and boys became paralyzed or suicidal post-shot. Have you heard the same?
Polysorbate 80 is a driver. I mean, that's what's used in chemo drugs to pull into the brain if we have glioma. Now, I think there's a different mechanism, and it's not polysorbate 80 of translocation from one site to another. And there's with that mechanism, so the brain releases a chemokine called MCP1, monocyte chemotoxic protein 1. The gut releases it as well. And the brain releases it when it feels threatened by, it's typically viruses. So I think it's more of MCP1 cause for translocation of an immune cell, macrophage, which has engulfed the antigen in the arm. And then it's called MCP1 recruits macrophages. So then you're recruiting macrophages to the brain. And I think that's the mechanism that's happening, not polysorbate 80 that's doing it. And there's research that's been done around MMR and that mechanism. And with that is when I use, maybe we can go into it, but Denmark has a different vaccine schedule. And they did a study they did a study on MMR and autism to prove that basically MMR doesn't cause autism. However, their vaccine schedule is different. It's quite different from the United States. And I think with that is their timing, and they start at 5 months and they do the MMR vaccine at 15 months. So I think that there's a grace period. I think there's also what occurred before the MMR, and why I will have parents, if they've never vaccinated, we start with MMR and then we do subsequent vaccines after that. When it comes to Gardasil, I think that it's the MCP1 as the mechanism, but I just know that there's been literature around MMR specifically in MCP1, and I would apply that to the Gardasil vaccine. Now, when you think of the adverse reactions, and that's my mission, is to understand the mechanism, therefore to find a solution, and therefore finding an optimization protocol. The Gardasil vaccine is very effective because of that adjuvant. It's a very strong adjuvant, which is why it's effective. Now, the safety component would be, even though it's very effective, how inflammatory is that? And so if we have high inflammation, that would allow for leaky blood-brain barrier as well. Are things moving in and out faster at a higher speed? Are there more cytokines that are part of that component? So I think there's way more moving parts than just polysorbate 80. It may have a part, but I do think that's probably MCP1 as part of that. And so also when I think of reactions is, what was the body like going into it? And you could overlap that with if you see people with Lyme disease, those that get bit by a tick or affected by Lyme, and those who aren't. And those who are affected are going to be people that have other issues and inflammation, and then add on just another layer and the body can't handle it. So there's genetics involved as well, which I'll speak on, is if you can be more primed to be more inflammatory and you don't have those off switches. So I think it's sort of a perfect storm that can occur. Yeah, Gardasil is its own vaccine because it's different, and it is still on the table of major discussion. And I do think that Merck, it's on its way, or has been, that they will be sued. So, and that's just a matter of fact. For those that sort of know more about it, but there's build up to a case, and so it's in effect, or it's going to be in effect. So hopefully that answers the question. Yeah. Okay. All right, I will move on and to optimizing vaccine efficacy. Okay, so nutrition plays a role. Who would have thought? Nutrition plays a role. So they're looking at malnutrition and immunology, and nutrition is key. I know I'm preaching to the choir on this one, but it's like new information to some people that nutrition can play a role in immunity, which then therefore translates to effectiveness of vaccines. So it being malnutritious, not having certain nutrients can cause immunodeficiency, and therefore you may not respond, or they may not respond as well to vaccines. So, and they made a paper on it, and this is where having certain key nutrients, zinc, D, A, selenium, C, play a role in immune support, and therefore a nice response to an antigen, and then therefore long-term memory, better long-term memory. Just a quick breast milk, super juice, and just threw this in there because I think it's cool to be reminded what breast milk contains and has and supports infants, and the immunological compounds that it also contains for babies. So just think that it's great. But babies fed is best. If we can do breast milk, awesome. And if we can have babies have supplemental breast milk, I think that's very useful. Things to optimize immune health, because going into making, this is in terms of vaccine efficacy, you need to have an immune system that can function, that can even respond. And these are some of the key things around optimizing and that are an important part of the whole picture. So gut health. So if someone has, major diarrhea, be it you have a SIBO case, they're not going to be celiac. So now you have an autoimmune condition. They're not going to be able to respond particularly as well to vaccines as they could be as a result of a gut health not being good. We want to make sure the innate function is happy, adaptive function, transfer factor, interferon, and then we, pull from specific nutrients to help fuel and promote the immune function. And so some things that are going to down-regulate the immune system, as you all know, of course, inflammation will do it, pharmaceutical drugs will do it, and a higher propensity of adipose tissue. So being overweight is also going to be part of why vaccine efficacy, part of the downgrade of vaccine efficacy. So paper just on the role of importance of GALT and how bacteria, particularly bacteria that help maintain healthy GALT. So it's been found that the combination of Bacteroides fragilis and Bacillus subtilis, which is a spore, promoted GALT development and led to a development of the pre-immune antibody repertoire. Probiotics. So there's been some evidence that there's some specific probiotic strains that can actually alter monocyte and natural killer cell function in blood. And they've shown that accumulation of taking some specific probiotics can boost antibody responses to oral and systemically administered vaccines, which is pretty cool. Probiotics and prebiotics, well, obviously, because prebiotics are going to feed probiotics, so we're talking like GOS, FOS, XOS, to nutrition for our probiotics so that they can be part of that immune response. They did prebiotics and probiotic supplementation with influenza vaccine, may hold great promise for improving vaccine efficacy. In the elderly, vitamins and influenza, so they noticed that seniors that had more of a nutrient-dense diet had more H1N1 antibody titers than those that didn't. Vitamin A and D and influenza in children. So double-blinded clinical trial looking at the effects of vitamin A and D supplement on efficacy of influenza in kiddos 2 to 8, and that found that children with low baseline vitamin A and D showed significant improvements in flu vaccine responses when given vitamin A and D. Vitamin C increases the chemotaxis of granulocytes and macrophages, increases phagocytic activity, and it was found high doses of vitamin C increases efficiency of immunization with human cell culture for rabies vaccine when they did that in guinea pigs. What's interesting is they found that 10 milligrams per kg per body weight was better than using 100 milligrams per kg per body weight. So actually a lower dose was just as, if not better, than higher dose. So vitamin C, this paper looks at elevated blood histamine caused by vaccinations, and vitamin C deficiency may mimic the shaken baby syndrome. So vaccines are inflammatory. To make memory is inflammatory. So with that can stimulate mast cell activation, and then we have histamine, and the vitamin C as a can help stabilize mast cells would be part of that. So vitamin C is absolutely part of my pre-post vaccine support as a result of this. So increased risk of influenza among vaccinated adults who are obese. So the seroconversion or seroprotection rates were different between healthy weight obese adults with influenza. So overweight that inflammation is going to downregulate your immune response, and therefore your vaccine won't be as effective. And I think that's super critical and important, and the public health should pick up on that. We want to be healthier overall. That would be something, no matter what, even but they would they would use it as a way to pull in the vaccine conversation, fine, because if that's what you want to do to help people lose weight and help them understand that certain nutrients are very important and being overweight can affect your immunity, then use that as a tool to educate people. I think it's really important. Okay, so we're going to move on to genetics. Everyone talks about MTHFR, and MTHFR being the reason that one cannot get vaccinated. So MTHFR, methyl tetrahydrofolate reductase, essentially helps the body convert the last step of folate into methylfolate. And essentially its point is to provide a methyl group, which there's other very important nutrients that provide that methyl group, and that's going to be SAM, E, and methylcobalamin. And so methylation, it's also, yes, involved in detoxification, phase 1 and phase 2, in terms of methyltransferases. So MTHFR. Now, MTHFR is here. I will assume that most of you have seen or know or familiar with MTHFR. So as an enzyme, it's the two last SNPs of the MTHFR that they're rate limiting, and that's why we look at those two specifically. MTHFR, I think, is 52 plus SNPs that make up that enzyme. But when those last two are genetically varied, then that reduces the ability to make methylfolate. And so in comes homocysteine to MTR, and then it converts that into methionine, into SAMe, SAMSA, and then you go back into homocysteine. So you go round and around. So methylfolate is used within detoxification, but it's not a big player when it comes to vaccination. I think that's really, you've got your blinders on if you think MTHFR is the reason and you stop there. You need to keep going when it comes to when we think around vaccines. Number one is going to be inflammatory off switches is going to be number one. IL-4, 2, from histamine, other ones, ICANN, mTOR big, PON1. So there's other genes to look at beyond MTHFR when we're going to talk about vaccinations altogether. And to me, the most important is the genetic off switches for inflammation. And if these ones don't turn off, then you are more prone to inflammation. And then that's where problems come. And that comes with surgery, head trauma, infections. You just can't seem to get over it. Be your genes. And so this is part of knowing, am I more prone to be an inflamed person? And be it that's empowering to you. So then you go into things that are inflammatory, meaning surgery, and you would prep your body for that. And then be it even vaccines, as well as why some people respond poorly over others. This would be part of why. Even in terms of non-responders, so HLA is really important in the role of making memory. They did this around influenza. Those that have genetic variation of HLA have a reduced ability to make memory. So, and there's a lot of people out there that are non-responders. I have a patient who had 2 MMR vaccines after each baby that was born because she had no rubella. And she had her MMR, had her baby, she was pregnant, no rubella, got her MMR, no rubella, had another baby, no rubella, so got another MMR. So she's like, okay, that's enough. I'm clearly not responding to rubella. So there's people, this is where part of where we want to achieve a 95% herd immunity is going to be impossible on so many levels, from non-responders to obesity, to malnourishment, I mean, you never achieve 95% herd immunity. It's impossible as a result of personal choices, and not knowing what you're doing is actually affecting your ability to make memory. And then this genetics too. Really, so we should be looking, what should we be looking for that can be downregulating our genetic SNPs? What is dirtying up our SNPs? If you've read Dr. Ben Lynch's book, Dirty Genes, from that perspective of, are we affecting our genetic SNPs? And if we are, don't do those things. Are there immunosuppressive agents we can be using to offset issues, possible epigenetic changes? So yeah, looking at the immunosupportive agents that we can be using to offset these issues. And usually, things like zinc and D and A are going to be those. And then are there nutraceuticals that we can use to help this overall process? Yes. And so that goes into vaccine optimization. So my strategy, our strategy, if you're going to work with someone around vaccine optimization, if you can, what you do within your office is what you do within your office. But for myself, and what I advocate for is, if you offer vaccines in your office, or if you speak about vaccines with your clients, patients, you should be offering a space of dialogue that is free from shaming, because that is when I go into language, which I didn't today. That language of shaming is the number one, I would put money on it, the number one cause of vaccine hesitancy. And as a naturopathic doctor, we're the lowest hanging fruit. So we're the one for the reason why there's hesitancy. And every single time I do a conference, I remind the audience that their language is the reason for hesitancy. Because if you shame someone and gaslight them, don't expect them to come back. And that has happened to me probably a good 100 times, where over the last 7-8 years of someone coming in traumatized by their experience, never vaccinated their kids ever again, and had no clue whom to go to talk to, because public health doesn't have the time nor care to give space to someone to talk, but it's always lined with a bit of gaslighting type of language, and so, or incredibly passive aggressive. So body language speaks volumes, eye contact speaks volumes, and a person is going to leave incredibly uncomfortable, confused. And when you come with really simple questions, a lot of my patients have very simple questions. I can choose to answer in a way that will belittle them, or I can choose to answer in a way that is kind and respectful. And I always choose that. And they come back. So that part's really important. I don't know why I have to talk about it, because that's what's happening. And that's the experience my patients are experiencing. Language, I use infection, not disease. Measles, infection; chickenpox, infection; streptococcus pneumoniae, infection. It's not a disease to have an ear infection that's caused by Haemophilus influenza. So it's infection. I think it's important for you to read vaccine inserts. There's a lot of information in there that, be it answers or brings up questions for yourself so that you can get better informed. I always, look at all questions answered. I always explore their concerns, and that's with or without vaccinating. We talk about the risks of their choices, vaccinating versus not vaccinating, how to support the child when illness arise, and have that all ready to go, usually, because just because you vaccinated does not mean you're protected from everything, because you're not. I encourage appropriate testing, so that we have more accurate surveillance. Patients ask me, well, what's the rate of streptococcus pneumonia for the pneumococcal vaccine? Like, no idea, because it looks like a common cold. Or Haemophilus influenza looks like a common cold. So really the triage is, you go in, you feel sick with a walk-in clinic, and they say, well, here's antibiotics, go home. They do not swab to know specifically what that child has, because it could be 101 reasons, 1,000, 1,000,001 reasons as to what's causing them to feel that way. But we do have the testing available, and we clearly know how to test for one specific virus, we can do the same for everything else. We can be at a better level of surveillance and have that. So better numbers. How do you treat a child with a diagnosed vaccine adverse reaction from mild, moderate, severe occur? I have never treated a severe from anyone that's vaccinated with me. Not even moderate, actually. I've had mild, which means fever. And I had one kiddo that I think he was he had a needle phobia and didn't know it. So when he got home, he had more of a headache. And he had the MMR vaccine, and so went home and he was totally fine the next day. But I think it was and I try to make it a fun experience. So that whole experience component, I try to quick and easy and in a gentle way. It's not so medical, but that's where, when I look at the BC CDC adverse reactions reporting system, they have a 3-page table format. And I look at those and I'm still trying to dissect, well, how, if that was to present itself, some of the adverse reactions are actually the infection itself. So measles or chickenpox, the actual infection presents post-vaccine. But other adverse reactions of how did that happen? And therefore, how would I prevent it? Those mechanisms. And typically it's going to be inflammation is part of why that happens. So this is where I have some tools in place that if we think that our child is presenting with a bit more inflammation, which means, yes, pain, not feeling well, then we intervene with some things at that moment. But typically the pre-vaccine protocol that I do, I haven't had to do that. Which is great. So some of these are what I do before. Really, it is use what's appropriate. If there's been a previous mild vaccine reaction, question mark, be it I will up some things as a result of that information. But this is sort of a baseline of what I'm going to be doing. Vitamin C for sure, 2 weeks leading up to vaccine. I am going to be using something along the lines of a probiotic, and then I'll use a probiotic that maybe has a prebiotic in it. Spore-based are more easily accessible. There's more companies that are offering, because Microbiome Labs in the States, they're the ones that started it. And so getting their products is it's coming. They're coming. They're getting an NPN number for their Megaspore. So it's coming. So then it'll be easier to access. And then good nutrition, vitamin D. I do use glutathione in everyone if I can, pre and post, even in an infant. It's just compliance is the problem you're going to have with glutathione, because it's not awesome to taste. And then I do homeopathics. So I do for drainage, and then I use single homeopathics pre and post as well. And absolutely no Tylenol beforehand. And then afterwards, if we can prevent it, I use homeopathy for fevers. And if anything, then we'll go to Advil if we have to use something for fever. But it's been like twice that someone's had to use something for fever. And then afterwards, we continue what we did before. We continue after for 2 weeks. And then I may add in some sulforaphane, depending on what age we're dealing with and compliance, what we can get into the person. And possible areas to think about would be reducing inflammation. So IL-6 interferon tumor necrosis factor alpha, TNFA. And then binders to charcoal can help with IL-6. Quercetin can help with IL-6 to help with reduction of those inflammatory cytokines, which is, if they perpetuate, then that's where the problems are going to come from, because it is inflammatory. And if we don't have those genetic off switches, and we're more prone to inflammation, then we're going to have more long-term. For vaccine sites, just coming from a TCM perspective, I ask that people don't vaccinate on meridians. And so the vaccines that are going to be sub-Q are going to be the back of the arm. The intramuscular are going to be following the large intestine meridian. So to just landmark away from that. Just a last thought. I have webinar series. There's 8 of them. It's probably 9 hours of information. They are for purchase on vaccineoptimization.com, but I go, infant immunity again, I go into pregnancy and breastfeeding, then I go into viruses that we vaccinate against, excluding COVID, because I made this before COVID. And then bacteria we vaccinate. So understanding what bacteria are, understanding what viruses are, and then what we vaccinate for. In the is it the bacteria one? I go into meningitis and orthopedic testing. I think it's the bacteria one that I did that. And I go into nutrients, of course, around how viruses are different than bacteria. I think that's important. So I usually suggest parents to go to webinar 3 and 4, because I think it's important to understand the infection that which a vaccine is available for, versus just not even talking about a vaccine first. Let's understand the infection first. Get to know the infection. What do you want some memory for? And then you make the decision of the vaccines that you want to do. You got to understand the virus first, or the bacteria first that's out there. And then I get into the vaccine schedules, efficacy, safety and efficacy, how that is done. Here I get into more of those SNPs. And this is where I talk about aluminum, and then basically how to optimize a kiddo's health overall, webinar 7. So it's away from vaccines completely. It's just how to help a thriving kiddo thrive. And then my approach to vaccine optimization. And that's it. That is it.
Thank you so much.
Yeah.
We had a couple of questions sent in advance. Do you mind if I ask you this? Do you have a couple more minutes? Okay.
No, I totally have time. Yeah.
Okay.
Totally.
So relating to the COVID vaccination specifically, you just kind of mentioned it in passing at the end. Are there any unique concerns with that group of vaccinations that you keep in your mind when you're helping your patients? And do you approach that decision making around those vaccines any differently than you would with other vaccinations on the schedule?
Yeah, the difference is going to be, I'm going to be doing blood work beforehand. So all through COVID mandates, I was doing, and since mandates are over, it hasn't been happening anymore, would be doing blood work beforehand. So just looking at immunity, clotting factors, autoimmune, just looking at things that Health Canada has shown that may change. And so then having that baseline is what I would do first. And then second, my pre-post, I put in melatonin post and using nattokinase post are 2 different ones that I add in. But the rest pretty much stay the same, except the specific homeopathics that I use change a little bit too. But those are 2 nutraceuticals that I will change post. Yeah.
Okay. In the Q&A, Nancy's asking, what are your thoughts on a slower vaccine schedule delayed with only 1 aluminum containing shot at a time to help prevent adverse reactions?
Yeah, a lot of my patients decide to do 1 at a time. Yeah. And then if there's an adverse reaction, I know which one to report to. So then, because when it comes to reporting, if your kiddo's done 4 at a time, that's usually the adverse reaction to that is typically dismissed because you don't know what to report. So it's not, no one reports it. So there's low reporting as a result of not knowing what to report when you have all 4, because that goes provincially, then it goes federally, and then they annually look at trends. Well, we're looking for trends towards a specific vaccine. And if we need to pull they need to pull a vaccine, then they're going to know which one to pull. But if you've done 4, then no one's going to report that because we don't know which one. Yeah. Yeah.
And the last question I have here that was sent in advance. So for those of you who are here live, if you have any last questions, get those in right now, because this might be our last one here. The question was, for parents who might lean toward prioritizing natural immunity over vaccination, For infections like chickenpox that are relatively uncommon now, does that change the risk benefit of hoping to wait and achieve natural immunity?
So I've only seen 2 families with chickenpox in my career so far, maybe 3. Um, Basically, the cutoff point of decision making would be age 12. I don't recommend doing live vaccines in puberty. So that transition when you're developing, there seems to be more inflammation occurring through that transition point. So you do it pre-puberty. And then, I mean, I've seen 4 adults with chickenpox. I saw 4 adults that which had had chickenpox in their adult life, which is not a big number. They got through it. It was uncomfortable, but the increase of chickenpox becoming a problem increases as you age. It's a childhood infection. It's meant for childhood. So with it, the chickenpox vaccine has reduced chickenpox. With that is we are in and I've had microbiologists at the BC CDC admit, he's like, we are in a vaccine dependable time now, be it that's good or bad. But you don't know when you're going to see it. You can't have a chickenpox party because you don't know when you're going to see it. So then the chickenpox vaccine then is a choice decision that be it because you don't know if your 10-year-old is going to be a super healthy 20-year-old that can handle chickenpox. You don't know. And be it the slim amount of exposure means what if the first time they see it in their life is they're 40. So those are things to consider because it can become a worse infection because natural immunity gives you it doesn't give you life. It gives you about 30 years of protection is natural immunity. But what nature intended is that you as a parent would be re-exposed when your 4 or 5-year-old got chickenpox, then you have that re-inoculation. And then when you're a grandparent, your grandbabies get chickenpox, and then you have a re-remembering to stimulate that again. But that's partly why there's more shingles. It's because there isn't that re-inoculation, and then those antibody numbers are declining. And chickenpox is part of the herpes family. So it stays with you forever. So then you have a major stressful event, and then that antigen comes back out again as shingles, depending on where on the body. So that's why the Shingrix vaccine is out. It's dead antigens, is not a live vaccine. So then to re-remind your immunity by doing the shingles vaccine. Yeah.
One last question here. Relating to the MMR vaccine, would you recommend administering it after 3 years old? She's saying she's seen this recommendation from another doctor.
No. And the reason, and I think because now more sophisticated of understanding MCP1. So I think it's the relationship with MCP1. And that's that recruitment to the brain it's nothing to do with blood-brain barrier. People think it's go by 3 because that one's the blood-brain barrier is closed. Your macrophage is going to get through that blood-brain barrier if it's closed or not. It's not a foreign identity. It's going to get through. So it doesn't matter if it's open or closed. So 3 I think 3 because the blood-brain barrier is closed. No, the mechanism is the MCP1. And so this is where I will do MMR first for families that have done nothing, and it doesn't matter what age. Well, you can't do it earlier than 12 months, but you can do 12, 15, 16 months too. Age doesn't matter. It's the fact that it's first, and then I will follow up afterwards. You can do 3, but really if we had all the vaccines and let's say you wanted to delay a bit, I would give it probably 9 months in between your last vaccine that was an adjuvant vaccine and then do MMR. Give about a 9-month buffer versus a 6-month buffer. I would do it at that point. Yeah. Yep.
Wonderful. Thank you so much for your time today and sharing all of this information and your expertise.
My pleasure. I am on Instagram, Dr. Taylor Bean. I didn't put it on here, but it's Dr. Taylor Bean, same on Instagram. And I trying to keep up with more vaccine 101 things for people. I have one a big one brewing in my head, but I don't know if I'm going to post it. I think it's maybe too much for people to handle. Or I just don't want to handle all of the comments. But I like to put a lot of vaccine stuff on my Instagram is where I put it. And so sometimes it's fun to go in there and see what's up, and people give them their own 2 bits, and sometimes it's interesting. So, and I learn stuff too. So versus Facebook, it's sort of not as a good platform to do it. So anyways, I'm over there. So yeah, for more, stay tuned for more.
That sounds excellent. Thank you again for sharing and for being here. Thank you to those of you who attended live, or if you're on the replay and still sticking around, thank you.
Awesome.
This was really great information, I think helpful to everyone who will watch it.